Hi.
Hello.
My name is Megan. I'm a PA student from South College. I'll be taking care of you today.
Nice to meet you.
Can you confirm your name, your age, and your sexual identity for me?
Yep. I am Jane Doe. I am 23, and I am a female.
Okay. And can you tell me where we are right now?
Yep. We're at South College.
And what day of the week is it?
It is Monday.
And who's president?
Donald Trump.
Okay, good. So my patient is A0 times 3. I'm going to start off by getting my patient's vitals. Can I get blood pressure, temperature, respiratory rate, O2 sat, and heart rate, and then height, weight, and BMI? So get those vitals. Okay, so Jane, can you tell me what brings you in today?
Yes, I've been having a cough.
Okay, a cough. And how long has that been going on?
About 4 days.
About 4 days, okay. Can you tell me if that cough has gotten better or worse since the 4 days?
Yeah, I would say it's gotten a little bit worse.
A little bit worse. Okay, is there anything that makes it better or anything that does make it worse?
When I lay down, it's worse.
Okay. Can you tell me where you feel like the cough is coming from? Is it like deeper in your chest? Is it like more of a throat cough?
It's kind of just like a tickle in my throat.
A tickle in your throat. Okay. Are you having any other symptoms with that? Any like fevers? Anything else like that?
My nose has been a little bit runny as well.
Your nose? Okay. Are you coughing anything up when you cough? Nothing? Okay, good. So just a dry cough.
Yep.
Can you rate your cough on a scale of 1 to 10? 10 is like really persistent, awful. 1 is like just a light cough.
Yeah, probably just like a 3.
A 3? Okay. Can you think of anything that could have like caused this? Anyone in your family sick or around you sick at all?
My brother is actually also sick.
Your brother is sick too?
Mm-hmm.
Okay. Have you had any similar symptoms in the past? You probably have had a cough before, but like, is this a persistent problem that keeps happening?
No.
Okay.
I don't get them very often.
Have you tried anything to treat it?
No.
Not yet. Okay. And then, is this affecting your daily living at all? Your sleep schedule, working,
No,
anything
it's just
like that?
kind of annoying.
Okay. Then I think that is fine. So I'm just going to ask you some questions about your medical history.
Okay.
Did you have any illnesses as a kid? Asthma, major allergies, anything like that?
Nope.
Okay. Do you have anything going on now? Any major illnesses that you need to tell me about?
Nope.
Okay. Have you ever been hospitalized for any reason?
No.
No. Okay. Any surgeries or procedures in the past?
No, I don't think so.
Nothing? No, like tonsils out, wisdom teeth, nothing like that?
Nope.
Okay. Do you have any allergies to any medications, foods, seasons?
I'm allergic to penicillin.
Penicillin? What happens when you take penicillin?
I just get a rash.
A rash, okay. Are you currently taking any medications, any vitamins, supplements, anything like that?
Nope.
Nothing, birth control?
Mm-mm.
Nope, okay. Are you up to date on all your immunizations? So
Yeah, I believe so.
you are everything. You got everything when you were a kid. You got your flu shot this year.
Yes, I did.
Good. Okay. Are you up to date on your screenings, eye exams, dental exams, all that?
Yep.
Good. Okay. Do you have any disabilities that I should know about?
No.
Visual impairments, hearing impairment, anything like that? No? Okay. Good then. I think that covers everything. Okay, and then just some questions about your family. Does anything major run in your family that you can think of? Diabetes, heart disease, strokes, anything like that?
No.
Cancers? No.
Mm-mm.
Okay. Parents are alive and healthy.
Yep.
Siblings at all?
Yeah, I have a brother.
A brother, healthy?
Yes.
Okay, cool. So then just some stuff about your social history. Are you married?
No.
You're not? Okay. Do you have any children?
No.
Okay. Do you smoke or have you ever smoked tobacco before? Any other tobacco products, vaping?
Nope.
No. Do you drink alcohol at all?
Not really, no.
Just like maybe occasionally, social?
Yeah, once a month.
Okay, and you've never really drank heavily?
Mm-mm.
Okay. Any other drug use, prescriptions that aren't yours, anything like that?
Nope.
Weed? Okay. Are you sexually active?
Yes.
You are? And how many, is that male, female,
Male.
both? Male? Okay. How many partners would you say you've had in the past, like 6 months or so?
Just one.
One? Okay. Are you guys using protection at all?
Yes, they use condoms.
Okay, is that every single time?
Yeah.
Okay, and there's no concern for STI or STD at all?
No.
Okay, great. What is your diet like? How do you eat? generally?
Pretty healthy. I try my best.
Veggies and everything?
Yeah.
Okay. How much water would you say you drink?
A few like large bottles every day.
Okay. And then caffeine?
Not really.
No caffeine. Okay. Coffee, energy drinks. Okay. Do you exercise at all?
Yes.
How often?
4 times a week.
Okay. And what type of exercise is that?
I run.
Okay. For like 30 minutes, hour?
Yeah, 30 minutes.
Okay. What do you do for a job?
I'm a school teacher.
School teacher? Okay. And you don't have any reason that you would have any exposures to like chemicals or radiation or anything like that? Okay. Have you ever been in the military?
No.
Okay. And then have you traveled overseas in the past year or so?
Nope.
No? Okay, great. Do you have any history of trouble with like depression, anxiety, more stressed out lately, PTSD, nothing like that? Okay. Then I think that is good for your history. I'm just going to ask you some like basic questions about your symptoms and such. If you have something, just stop me and be like, I have that. Okay. So any weight changes, appetite changes, fever, chills, fatigue, any rashes, atypical moles, dryness, itchiness of your skin, any headaches, injuries of your head, deformities, any vision changes, any blurred vision, tearing, any discharge from your eyes, any hearing changes, sort of dizziness, room spinning, drainage from the ears, redness. Okay, any bloody noses, nasal, you said your nose was running a little bit. Is there any like pain in your sinuses at all? No? Okay. Then any bleeding of your gums, any like sore throats?
Other than just the cough, it's not really
Yeah,
sore though.
but it's not sore, no pain with that. Okay, good. No dry mouth, anything like that. Okay, any stiffness in your neck, any goiters, nodules, anything like that? Good. Do you do self-breast exams?
Yes.
Good. And then have you seen any like, or felt any nodules or like any dimpling, anything weird there? No, good. Okay, so you have the cough, you said. Any like wheezing with that, shortness of breath? You said you're not really coughing anything up.
No.
Is it worse when you like lay down? It is? Okay,
Yeah.
But no coughing up blood either. Okay, good. Are you having any chest pain?
No.
Palpitations of your heart? Any like swelling, edema in your hands and feet? No history of murmurs or anything like that. Okay, good. Any stomach pain, nausea, vomiting, diarrhea, constipation? No. Any trouble peeing, like pain when you pee, frequency, peeing a lot, not peeing enough, anything like that? No discharge down there, anything like that? Good. You said you identify as a female.
Yes.
When was your last menstrual period?
2 weeks ago.
2 weeks ago. And when was your very first one? What age?
When I was 13.
Okay. And has there been any like complications with that? Any like major pain, excessive bleeding? It's regular.
Yeah.
Okay. Good. Have you had any muscle pain, any joint pain or stiffness? No swelling, redness, that kind of thing? Okay. Any like temperature intolerances? So you're like the hottest person in the room or the coldest person? Excessive thirst, excessive urination? None of that? Okay. Any seizures, passing out? You said not really any dizziness. Okay. You said you don't really have any trouble with like anxiety, depression, suicidal thoughts, homicidal thoughts, or ideations. Any history of anemia, easy bruising, easy bleeding, and then any like color changes in your extremities, temperature changes, they're really cold, no history of DVTs, anything like that.
No.
Okay. And I think we can jump into the physical exam. So I'm just going to have my patient undress for me, just her shorts and her sports bra. While she's doing that, I'm going to wash my hands real quick and do my general exam. So my patient is a 23-year-old white female, has good posture, is in no acute distress, is ANO times 3, is well nourished, and looks well groomed.
Okay, I'm going to begin the skin exam. My patient would be completely undressed with a robe so that I could see the skin fully. I'm going to start with inspecting, so I'm looking all over the skin for any rashes, any discoloration, any bruising, any atypical moles or lesions, any lacerations, anything like that. So I'm going to make sure that I look all over the arms, on both sides, looking underneath the arms, looking in the axillary area, looking at the face, the chest, the abdomen, the fronts of the legs, the tops of the feet. I'm going to have you turn around, looking at the back of the neck, on the back, looking at the backs of the legs. I'm going to have you lift your feet up so I can look at the bottoms of the feet. Great. Can I have you turn back around? Making sure to look in between the web spaces of the fingers and at the palms of both hands. Perfect. And then I'm going to be looking at the fingernails and toenails, at the shape, the color, looking for any clubbing, any signs of thickening or brittleness in the nails, checking capillary refill, making sure it's under 3 seconds. Very good. Feeling the temperature and texture of the skin, checking for turgor and mobility, checking moisture of the skin. Great. And I would do the same thing on the toes and the feet. And then I would check the hair, feeling the hair for texture and distribution, looking for any signs of alopecia, looking at the eyebrows, the eyelashes for any signs of hair loss there as well, looking at the sclera and conjunctiva to make sure there's no signs of jaundice or any discoloration there.
Okay, so we're going to start the HENT exam. I'm just going to start by examining my patient's head, so looking for any obvious deformities. I'm going to palpate the head, make sure there's no tenderness there, and then kind of look for any lesions on the head. Good. Head is normal cephalic atraumatic, and then I'm going to move down to the face, make sure it is symmetric. So can you puff out your cheeks for me, and then smile, frown, raise up your eyebrows. Good, so face is symmetric. And then moving on to the eyes, I'm going to start with just some observations. So looking at the eyebrows, the lids, the lashes, and then looking at the sclera, making sure it's white and conjunctiva pink. Looks good. And then for special tests for eyes, I'm going to kind of start with our visual fields. So if you can turn a little bit for me. Thank you. So when you can see my fingers, just let me know.
Yes.
Good.
Yes.
Good.
Yes.
Good. Okay, so my patient's visual fields are intact. So then I'm going to do visual acuity. I'm going to take my card and just go about 2 card lengths away. And can you cover one of your eyes and read the bottom line for me?
563297.
Good. And then cover the other one and read it backwards.
792365.
Good. And then with both eyes?
563297.
Okay, good. So my patient's vision is 20/20. Then I'm going to do my pen light exam. So turn on my pen light and then shine it in each eye twice, looking for direct and consensual pupil restriction. And then I'm going to ask my patient to look at my finger and then follow it out and follow it in, and then look at my finger, look at the wall, my finger, look at the wall. Good. Okay, so my patient's pupils are round and equally reactive to light, and accommodation and convergence is good. So then I'm going to do my extraocular movements. Okay, so I'm going to have my patient follow my finger and follow it out, up, down, back up, and then I'm going to pause looking for any nystagmus, and then across, up, down, pause again for nystagmus, so I don't see any nystagmus, and then my patient's eyes are UMI, meaning extraocular eye movements are intact. Going to do my fundoscopic exam, so I'm going to turn off the lights and I turn on my fundoscope. So I'd use my right hand, right eye, so just looking for the red reflex and then following it in, getting really close. And I'm going to be looking for the cup to disc ratio, for any papilledema, for any AV nicking or cotton wool spots. So that was all normal there. And I'm deferring the corneal reflex because that hurts. Okay, so then we will move on to our ears. So I'm going to start with just some external observation of the ears. Just looking at my patient's ears, seeing if there's any like redness, any drainage, any swelling, and then I'm going to do a little palpation. Feel if there's any tenderness on the ear. Palpate the mastoid and the tragus as well. See if there's any tenderness. Make sure I do that on the other side. bilaterally, so nothing there. Going to set up this and then look inside my patient's ear. So using my right eye, pulling the ear posteriorly. I'm going to look in the ear and I'm going to look to see that the tympanic membrane is intact. It's pearly gray. I can see the cone of light. There's no swelling. There's no redness, no excessive cerumen, anything like that. The canals are open. Good. Okay. So then I'm going to do my rub test. So I'm going to stand behind my patient and I'm going to ask her to tell me which ear she hears me rubbing in. Good. 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 Okay. And then I'm going to do my Weber and Renee test. So starting with Weber, I'm going to ask my patient to tell me which ear she hears this in better, or if she can hear me equally in both.
Equal.
Good. Okay, so then I'm going to do my Renee test, looking to see that air conduction is greater than bone conduction. So can you just tell me when you stop feeling this? Stop. Can you still hear it?
Mm-hmm.
Good. Okay, so I did on the other side and make sure that air conduction is greater than bone conduction. Good for ears. Okay, so then I'm going to move on to the nose. And face me down. So just looking at the external part of the nose, making sure that the septum is not deviated. Everything just looks normal. I'm going to palpate the sinuses. You have your maxillary and your sinus, or your frontal sinuses. So making sure there's no tenderness there. Palpate the nose. Just make sure that's not tender either. Okay, and make sure you don't see any drainage or anything like that. And then I'm going to look up my patient's nose, make sure that the turbinates are patent, make sure that the mucosa is pink and moist, there's no excessive drainage, I don't see any polyps or anything like that. I think that's good. And then just making sure that my patient's nostrils are patent. So can you occlude one nostril for me and blow out? Good, and then the other one? Good, okay. So I think that's it for nose. And then we can move on to the mouth. So I'm going to start by looking on the outside of my patient's mouth, making sure the lips are not blue, which would be a sign of like cyanosis, making sure I don't see any like crusting, they're just normal appearing. And then I'm going to have my patient open her mouth for me. And I would look inside and observe. So I'd start by looking at my patient's pharynx. You can close your mouth for me. So I'd start by looking at my patient's pharynx, making sure that there's no redness, there's no drainage from it. Looking at the tongue, making sure that looks normal. The cheeks, there's no signs of trauma, biting the cheeks at all. Looking at the tonsils, seeing if they're present, 1+, 2+, any exudates from the tonsils. Looking at the uvula, making sure that's midline. Looking at the palate, making sure there's no petechiae or swelling or anything like that of the palate. Looking at the gums, making sure they're not bleeding, normal color and everything. And then looking at the teeth, the dentition, making sure that there's no decay or anything like that, and then no signs of oral cancer in the mouth.
Now we're going to begin with the neck exam, including the thyroid and the lymph nodes. So first I'm going to start out by inspecting the neck, looking for symmetry, looking to make sure the trachea is midline. I'm going to have you swallow, make sure that everything looks good. I'm going to have you move your neck around, just make sure everything is mobile, no issues with range of motion. Okay, great. And before I touch the neck, I'm going to listen for carotid bruits. So I'm going to listen with my bell. I'm going to have you hold your breath and release. Hold your breath and release. Okay, great. No signs of bruits. And then I'm going to have you turn towards that. Yep. And begin the thyroid exam, making sure to be behind the patient. I'm going to place my fingers over the thyroid. Go ahead and swallow. Locating the isthmus and feeling it rise, and then palpating each lobe bilaterally, feeling the size of the thyroid, feeling for any nodules, goiters, anything like that. Everything feels good. Okay, and then I'm going to begin the lymph node exam. So I am going to start with occipital, postauricular, preauricular, tonsillar, submandibular, submental, feeling the anterior cervical chain, the posterior cervical chain, and have you turn your head to the left, and then feeling the deep cervical chain to the right, and the deep cervical chain, and then supraclavicular, infraclavicular, axillary, and then epitrochlear. Okay, now we're going to begin with the pulmonary exam. So I'm going to start off by inspecting, looking to make sure the AP diameter looks normal, so no signs of barrel chest. Looking for any signs of accessory muscle use or labored breathing, so looking for at the ribs for any retractions. Looking for any signs of cyanosis, any signs of tripoding or trouble breathing. Everything looks good. So then I'm going to go ahead and palpate, so any pain. Okay, I'm going to have you turn to the side. I'm going to test chest expansion. So I'm going to place my thumbs equal distance apart on the 10th rib and have the patient take a deep breath in and out. Watching to make sure that my thumbs move equal distance bilaterally. Looks good. And then I'm going to start with tactile fremitus. So I'm going to place my hands on the patient's back using my ulnar surface of my hands and have the patient say 99.
99, 99, 99, 99.
Okay, so in 4 spots on the posterior, and then now switch to the anterior. So go ahead.
99, 99, 99.
Okay, so looking for any increase or decrease fremitus. Sounds good. And then I'm going to have the patient turn back around, and we're going to do diaphragmatic excursion. So I'm going to start with having the patient take a deep breath in, listening for dullness, and then I'm going to have you take a deep breath out. Okay, and finding that distance to where the diaphragm lowers and raises, and then doing the same thing on the other side to make sure that it's bilateral. Take a deep breath in. Okay. Okay, so it should be about 3 to 5.5 centimeters bilaterally, making sure that it is equal. Okay, great. And then I'm going to begin with percussing the lungs. So making sure to hit all my spots. Go ahead and just breathe normally. Using the ladder fashion. Okay, great. Go ahead and turn around. Making sure to do the spots anteriorly. Okay, great. And then I'm going to begin auscultating. So we can go ahead and just start on the front. I'm going to have you place your hands on your hips and breathe in and out through your mouth whenever I move my stethoscope. Again, using the ladder fashion, looking for any signs of adventitious breath sounds. Okay, go ahead and turn around. Doing the same thing on the back. Crossing your arms in front of you. Okay, great. So listening for any wheezing, rales, crackles, rhonchi. And then we'll move on to special tests. So I'm going to have you once again turn to the side. And I'm going to start with egophony. So I'm going to place it, or we'll do it in each of the spots again. And I'm going to have the patient say E every time I move my stethoscope.
E, 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 E.
And then I would repeat that for all of them, listening for if you hear an A instead of an E, that would be abnormal. And then we'll do bronchophony. So I'm going to have the patient say 99.
99, 99, 99, 99.
And repeat that for all the spots. And it should sound muffled, but if it sounds loud and clear, then that would be abnormal. Okay, now we're going to begin the cardiac exam. So I'm going to make sure that my patient is laying supine with the head of the bed raised to about 30 degrees. I'm going to start with looking for any JVD. So I'm going to have the patient turn their head to, There you go. Looking at the internal jugular vein for any signs, or for the highest point of pulsations. I'm going to place a ruler at the sternal angle, and then using a straight edge, I'm going to place that at the point of highest pulsations and measure it from the sternal angle, and it should be about 3 centimeters. And then that would be normal. So then I'm going to move on to inspecting the chest, looking for any scarring, looking for any pectus excavatum, looking for any signs of a pacemaker or anything like that. And then I'm going to begin palpating. So I'm going to start with my finger pads, feeling for any heaves and lifts in all 5 spots. So aortic, pulmonic, Erb's point, tricuspid, and mitral. And then I'm going to do the same thing with the ball of my hand, feeling for any thrills, aortic, pulmonic, Erb's, tricuspid, and mitral. Okay, and then I'm going to move on to auscultating. Again, in all 5 spots, listening for any murmurs. I'm going to start with my diaphragm, aortic, pulmonic, Erb's point, tricuspid, and mitral. And then again with the bell, aortic, pulmonic, Erb's point, tricuspid, and mitral. Again, listening for any murmurs or abnormalities. And then I'm going to have the patient roll onto her left side in the left lateral decubitus position. And I am going to auscultate with my bell and my diaphragm in the mitral position, listening for any mitral murmurs. Okay. And then using the bell. Okay, and then I'm going to palpate for the PMI in the same spot, the apex of the heart. Okay, great. And then I'm going to have you sit up and lean forward. And I'm going to listen for any aortic murmurs in the 4th and 5th spot. I'm going to have you take a big deep breath out. Okay, and again. And then I'm going to do the same thing with my bell. Deep breath out, and again. Okay.
Okay, so now we're going to start our GI exam. So I'm just going to start by inspecting my patient's abdomen, looking at the shape of the abdomen, making sure there's no distension or malnutrition or anything, getting down to eye level, and then looking for any signs of surgeries, any discolorations, jaundice, anything like that, making sure I don't see any bleeding or anything, and then looking for aortic pulsations as well. So that all looks good. So I'm going to start auscultating using the diaphragm of my stethoscope. I'm going to auscultate all 4 quadrants, just listening for active bowel sounds, and then I'm going to listen over the liver and the spleen, making sure that I don't hear any friction rubs, because if we had splenomegaly or hepatomegaly, they'd be rubbing against things, we'd hear that. And then I'm going to listen with my bell for any bruits. So I'm going to start with any aortic bruits, and then renal, and then iliac. And we're going to defer femoral bruits. Then I'm going to move on to percussion. So just starting with percussing all 4 quadrants, making sure that I hear tympany and not too much dullness, because that would be a sign of a mass. And then I'm going to percuss, starting with the liver. So I'm going to percuss, starting at the umbilicus, I'm going to percuss up and wait till I hear dullness, because that would be where my liver is starting, and then percuss back down to get the size of the liver. And then on my right mid-clavicular line, do the same thing, percuss up, wait till I hear dullness, because I'd be in the liver, and then back down and take those measurements. My mid-sternal line should be about 4 to 8 centimeters, and my mid-clavicular line should be about 6 to 12 centimeters. And then for assessing for any like splenomegaly. I'm going to start by percussing right under the rib cage, and I'm going to have my patient take a deep breath in for me. And I'm going to keep percussing as she does that. Thank you. And if I hear any dullness, that would be a sign of splenomegaly, because her chest cavity would be pushing all of her organs down, so I would hear her spleen if it was big. And then just percussing the epigastric bubble as well, making sure that's tympanic. That's the top of your stomach where there's air, so that should be tympanic as well. Okay. So I'm going to move on to palpation, just starting with light palpation of all 4 quadrants. I'm going to look at my patient's face to assess for any tenderness, making sure I don't feel any masses as well. And then I'm going to go under my patient's rib cage to assess for liver size, make sure I don't feel for any hepatomegaly, and then I would come over to the left side, and then I would hook under my patient's left rib cage to feel for any splenomegaly as well. And I think that's good for the patient. So you shouldn't feel any masses, obviously, and your patient should not be tender at all. And then I'm going to do just feeling for the kidneys as well. So you just put one hand on top and then one hand underneath your patient and kind of try to like catch the kidney. So you're doing a motion like this, trying to catch a kidney, and do that on the other side as well. And then assessing for CVA tenderness, I would have my patient sit up for me. There we go, move that way, thank you. And then I'm just going to kind of go like that, hold my hand flat, and knock against it like that, just feeling to make sure that there's no tenderness of the kidneys or anything like that. Okay, so these are some of your special tests for your GI exam. You're going to want to start by always making sure that if your patient is over 40, that you state that you would do a DRE. And then for special tests, I'm going to start with Murphy's. So I'm going to just palpate right where we do all of our liver stuff, so right under the right rib cage. I'm just going to hold a pretty like deep palpation there, and I'm going to have my patient breathe, take a deep breath in for me. Good. And so if my patient had any gallbladder inflammation, when I was pressing on there and she breathes in, it's going to catch and hurt really bad, and she's probably going to like jolt with pain. So that's Murphy's sign. And then I'm going to go in the right lower quadrant and just hold a palpation there for McBurney's. So McBurney's is down here, and that's just a test for appendicitis. You're just going to push on that, and if they have appendicitis, it'll probably hurt. Brobsing's also for appendicitis. You're going to go in your left lower quadrant this time, and your patient might have pain. You're going to palpate down. Your patient might have pain on the rebound. So when you lift your hands up, you're going to be feeling down here. When you lift your hands up, that might be painful for the patient. So Murphy's for the gallbladder, McBurney's for the appendicitis, and then Brobsing's also for appendicitis. The last two are also for appendicitis. I'm going to do obturators. So I just take my patient's leg, hike it up like this, and then I kind of just move it out and in. And again, if they have an inflamed appendix or ruptured appendix, it's going to be very painful in that right lower quadrant. And then I'm going to have you turn to your left side for psoas. So for psoas sign, I just take my patient's leg and I move it back like this, and that's going to be painful. And you can even ask your patient to push against your hand when it's in the back, so push against me. You're good, you can lay down normally now. And again, if they have appendicitis, when they go to like push that leg back, that's going to hurt really, really bad. Okay, so now we're going to do our peripheral vascular exam. So you're going to start, we already listened for bruits during our neck exam, so we don't have to do that again. I'm going to start by just feeling for the carotid pulses, one at a time on either side. Don't do both at the same time because that's going to cut off blood flow. And then I'm going to feel for brachial pulse, radial pulse, popliteal pulse, posterior tibial, and then dorsalis pedis. And so you're just making sure that all of your pulses are 2+, and then regular rate and rhythm in all pulses as well. And then I'm just going to assess the hands and the feet, looking for any edema or color changes, cyanosis, anything like that.